for this part of our session, our topic is emergency medicine in war zones. And I'm going to put both Giles and Rashad under the spotlight over the next 30 to 35 minutes with a series of questions. The first question is to both of you. So could you tell us all a little bit about your background relating to the emergency care during periods of conflict? Do you want to go first?
Would you like to start?
Oh, me? Okay. Oh no, I was hoping you would, Rashad, because you're actually genuinely experienced, and I'm not. So okay, I'm a bit of an interloper. So my experience perhaps is a lot more limited than Rashad. So I had been in the Army Reserves as a medical officer for about 10 years, and never got deployed. So I had all this training in conflict medicine, both in sort of the acute trauma stuff, but also in what culminated in me doing the diploma in medicine and conflicts and catastrophes, if I've got the full words in the right order, DMCC, that Society of Apothecaries does. So I'd had all this training, not been able to put it into practice. And then I was able to deploy in 2022 to Lviv in Ukraine as part of a disaster assistance response team with Samaritan's Purse UK, which is, sorry, Samaritan's Purse, not UK. It's an American-based Christian NGO, and spent a month in a field hospital there, mainly providing care for internally displaced people. So very limited experience. Rashad, you have got so much more.
Thank you, Giles. So I started emergency medicine as a residency in Egypt. Then at that time, I was fascinated by the concept of disaster medicine. Like, I'm super addict for adrenaline. Then I thought emergency medicine is not having enough adrenaline, so let's go towards it. I moved to UK with all the pressure in the NHS. I decided let's go to more pressure somewhere else. I joined I4C, then I got deployed to Syria, Libya, Yemen, different countries and Gaza recently, and different profiles, starting from practicing emergency medicine to being in charge to setting up the hospital, setting up the whole clinical service around the support that's needed for the conflict. There is a lot that I have been learning throughout the whole process of being deploying to a conflict zone, and I cannot agree anymore with the previous two talks about bi-directional learning of emergency medicine across different settings. Megan, I think you are muted.
I knew that would happen at some point. My second question again is to you, Rashad. How do you personally prepare for deploying to war zones in your capacity as an emergency physician?
Deploying to a war zone, you need to prepare yourself throughout the holistic preparedness across multi-dimensions, physical, culturally, and also technical. On a physical level, it's very crucial to ensure that you are in optimal health before deployments. That's including do all the necessary checkups, all the vaccination, all the tests, everything you have been delaying while you are in a normal setting, that needs to be done before getting to the conflict zone. Sometimes or most of the time, conflict zone are very high stressful environment with sometimes limited access to healthcare. So your well-being is very essential to be able to provide at these settings. Next is culture. Part of the preparedness is prepare to understand the norms, the belief, the practice of these communities. What are very vital to these communities? What are considered respectful? What are considered as offensive? Gender roles, communication style, even religious customs. The culture competence not only helping you to avoid misunderstanding, but also build the trust and the acceptance within the community. Lastly, the technical side. You need to familiarize yourself with the health profile of the area, including the prevalence of the disease, existing protocols, local health infrastructures, and understand how health systems function with the resources available in these countries, and how to coordinate with local and international actors that's working in the field. Proper preparedness, preparing across these layers, ensuring the safety and support and dignity of the people you are serving during that mission, which is essential core ethics and value of providing support in emergency, in conflict, or in any humanitarian context, is keeping the dignity of the population that we are serving.
Thank you. And again to you, what are the challenges, do you think, that are common to working in zones of conflict?
One of the biggest challenges I see me going through it, and as a supervisor seeing different clinical or emergency physician getting through it, is understanding that this clinical practice is not only about evidence-based. It's about how systems are function in these different settings. So when we are encounter with a fact that is, even in many of our day-to-day clinical practices, it's guided by the governance, it's guided by the resources, it's guided by how the system is built with each other to build up the whole holistic healthcare system. So what is available in the UK setting might be not available on the other setting, and the other way around. So what's the privilege that the emergency physician can do in a certain setting could be bigger or even lower than the UK context. And that's sometimes one of the biggest challenge because it's beyond the clinical practices. And other challenge is also facing a new type of cases and new presentations. And that's where comes the very vital point of learning from local doctors, local physicians. How many of us has been encountered with Ebola before? But if you go to Uganda, that's pretty much day-to-day things. So in many cases, they would understand more what are the system able to provide, but also what are the clinical protocols that we can learn from. Using low resource, and here you can you would be surprised with the amount of or the capacity of what we would consider as a low resource to provide for their own population. So getting the example of Dr. Giles about the ultrasound, how amazing they are using the ultrasound to the extent of finding out things that we would usually do CT for, finding out things that we even might need a higher specialty consultation to do. But the training of emergency physicians at these countries or at this level with a low resource setting might be encouraging people to learn to that extent of competencies in ultrasound. So these are the three main challenges I have been facing and getting through, and I have learned a lot through these challenges.
Thank you. Moving back to Giles now. What are the key lessons that you think we can take away from your experiences?
Yeah, thanks, Megan. So I guess a big difference between so Rashad has done this like for real for a job, and I did it as a 1 month attachment. And for many of us, it's going to be more like that. So I think my learning was kind of a lot of it was that just getting to grips with the challenges in something that I've not done before. So I've worked in plenty of low resource settings before, but in a conflict zone, even though in this particular case, Lviv was way behind the front line. We were supporting IDPs in their various centers rather than frontline acute care. And so some of the lessons that I learned, I guess, is dealing with the lack of resources, the discomfort of living in a tent in a multi-story car park, which is what underground car park. We were in tents in a car park. Sometimes you go 48 hours without going outside because there were what's the word I'm looking for? The sirens were going because the rockets were coming in. We actually never got hit by a rocket, but the sirens would still be going off every night, and sometimes it would be quite a lot. You'd be not allowed out. So it was that security thing that I think was new, and was one of the sort of the lessons that I learned about how to never having had that before. What social media allowed you to use, not limiting where you can go outside the building, those kind of things. That was quite hard. But the lessons that are generic to all of this is a huge respect for those who actually live there. I was there for a month. I knew I was coming back. Those guys who the medical students we were working with, who were actually in the healthcare, they weren't coming back with us. And it was it's a quite a humbling thing. I mean, you do feel, you realize you're an interloper, and these guys are in it for real. And most of the medical students with us were women, because the men had already been deployed. And one of the guys with us was then about to deploy to the front line. And I just huge respect for them and their resourcefulness and their resilience. Yeah, I think the other huge thing that I learned was the importance of teamwork, of a common purpose. And this was, I think, the thing that was most striking for me, coming from the NHS, where we're just full of silos and turf war, and there really isn't a common purpose. Whatever we're told, we're always told we're all the same, we're all on the same team. That's nonsense. It really isn't, is it? Everyone, I'm sure, who works in the NHS will recognize that so much of what we do is a battle, referrals, adversarial. People don't want to take the patient. It was absolute joy that the entirety of our team were clearly on the same side, on the same page, and properly working together. I've not experienced that before anywhere. So that was, I think, the key lesson for me was the importance of genuine common purpose. And I'm sure that's not true everywhere. I'm sure there are plenty of places where that resilience breaks down, the teamwork breaks down. But I saw it, I think, at its best. And that was a really important learning experience for me, I think.
Carrying on that subject, under being out in Ukraine, was there anything that surprised you about the situation of refugees out there?
Yes. So it's not so much my experience. I said, I knew I was coming back after a month. We were working with IDPs, so internally displaced people. So technically, you're a refugee when you cross an international border. And this I had never been aware of before, was that obviously, so don't hear me wrong here. Obviously, it's an awful thing to be a refugee, to be forced away from your country. But what I realized working with the IDPs is that an awful lot of them were unable to become refugees. They wanted to leave the country. They wanted to go to Germany or Poland or wherever, but they couldn't because they didn't have the money and they didn't have the contacts. And so there were some who came through. We met and said, "Oh yeah, I've managed to, my mate who's a lawyer in Birmingham, he's managed to sort of pay for my flight from Poland, and I'm going to go and be a refugee." And you suddenly realize actually that the IDPs were in a really, really difficult situation, and that they were, in general, the poorer. There was more mental health, chronic illness among that group. And I just had never appreciated that before. That actually the people who are left behind in the country are often in an even worse position. And I think they often get forgotten about because they're not in your country. They haven't got to you. So you don't see them. So you're not setting it. And yet they're there in their country, which is less able to look after them, even though they were technically entitled to free healthcare. They couldn't access it. Your country's already overloaded. So what are you going to do with this whole centre that's got hundreds of people now needing healthcare because they're away? and needing more healthcare because they're chronically ill. And wow, that was a real eye opener. And yeah, sort of difficult to process.
Thank you, Giles. We're moving back to Rashad now. How do you adapt to the return to normal life after your experiences working abroad?
Very hard question. Never. So once you return from conflict zone, it's truly life-changing experience. It's an eye-opener. You come back with a deep sense of gratitude, realizing how privileged you are, even the simplest thing, clean water, food, place to sleep. Feel like luxurious when you witness firsthand how many people in places like Gaza, Sudan, Ukraine are deprived from this. Then it became your moral responsibility and part of your mandate to speak up for the vulnerable, for those who may never have the platform to express their needs or suffering. As it's hard as it may be, but once you return, you start new missions immediately to be the voice of the people in. A wise man once say, the greatest tragedy of the world is not the actions of the bad people, but it's the silence of the good. It takes sometimes to reflect. My advice, don't push yourself. One of the feeling that's always we will always get is the sense of guilty of leaving people behind. That's pretty much a constant feeling. That's it, especially when you move to a place where everything is available. But that's part of the process and part of reflections, and use that as a fuel to push for the new missions, speaking for the inequity, speaking for the international humanitarian law, speaking for the right of the people to access healthcare wherever, whenever, regardless their situation. That's one good coping mechanism I have discovered, and I'm just sticking to it. Start the mission immediately after coming back, the mission of being the voice of the people.
Thank you. I appreciate that's probably, as you said, a difficult question to answer. The final question that we've got at the moment, and we've got a few more on the chat. So for both of you, if someone in the audience was considering getting involved with organisations that support the medical care of patients in zones of conflict, what advice would you give to them?
I would start with try to engage with the organization who have an experience on that. As my other hat as an operation manager, it's really the responsibility of safety, security, communications, logistic, moving equipment, finding out the resource, everything that is preparing the environment for you to be emergency physicians to practice in conflict zone lies with other people, with other profile that is within the organization. So try to find the organization that is have that kind of experience and really have the competency to give you that environment and prepare that environment for you to practices. That would be one of the advice I would always recommend, is to find that organization which is alleviate your burden for taking care of your safety and security. Still, your safety and security will still in your responsibility, but there is a whole machine that's built for you to support you in that particular field, which is safety and security. And Dr.
Yeah, I'd strongly echo that. I might go one step further back and say, I think the question was considering getting involved with an organization. I think, yes, get involved with that organization. And what I mean by that is, don't think you can do this alone. You know, a group of you saying, we're going to go off and do something. People used to do that in the past. It's a nightmare. And it's kind of obvious. And I don't think any of us would imagine we would do that. Although a lot of us do think we can do that in non-conflict, low resource settings, which is probably also not great. But the sort of moving up one step from that, the experience of the tsunami in the late noughties was that there were loads of small organizations trying to do stuff, duplicating unnecessarily, lots of redundancy, lots of stepping on toes. And that was, I think it was about that time that was why UK Med or UKI ETR was set up. And so properly joined up thinking between organizations is really important, and organizations that work well together, providing all that logistic support, is true of any kind of low resource catastrophe kind of work. But I think I would definitely want to echo on top of all of that, in the conflict arena, the importance of safety and security. And if the organization that you're working with does not make that a priority, I would go to a different organization. And I was really impressed with the training I had, and the not just the training, but the clear priority that it was every single day in terms of security briefings and keeping us up to date and making sure that all the processes were followed. So yeah, really crucial.
Thank you. I hope that answers one of the questions from the chat. We've got a couple of other questions that it would be helpful if you both could answer. So the first question has sort of semi been answered anyway, in terms of how do you safely provide medical care in active war zones. But the other part of that was about, whilst you're out there getting time to rest and manage your mental well-being whilst you're in those environments, is that something that you work on, that's supported, etc.?
If I may, so this is one of the biggest reasons that Dr. Giles and I are recommending organizations, because big organization will take into the consideration your mental well-being as important as your physical well-being and safety. So most of the big organizations that work in the conflict field will have the experience of providing mental health support during the conflict. However, and getting back to what Dr. Giles mentioned before, it's when there is a one purpose, you will get surprised by your surrounding resilience, and you will discover your self-resilience. Walking the giant within, if we are using that word, there is the giant within every one of us when it's come to a clear humanitarian noble purpose. Then I have been in this field for 15 years now, and I haven't encountered a lot of nervous breakdown from physicians and nurses in the field. Mostly after they got out of the field, they will start reflecting on it. But during being in the field, with the resilience of the locals surrounding you, because eventually these locals, if we speak about Gaza or Sudan, Ukraine, or any of these war zones, have much more pressure than you have. Their family is in danger, their livelihood is in danger. But while you would find them still working, still eye on the purpose, still doing the job, still have this resilience. And that resilience is contagious. Then you will find out yourself performing very well. The challenge will be when you come back, and this is why most of the organization will have a system for debriefing, psychological support within the field, but mostly when you come. That's from my experience, and if Dr. Giles.
Yeah, again, I'd echo that, and in my experience of N equals 1, just to sort of anecdotally, just sort of explain how it might seem so counterintuitive, but so we were working pretty much every day for about 14 hours a day, and even when you weren't working, you were still there because you're in a car park in tents, and you were just surrounded by people who were just doing their shift. So we would do our shift, and it would be like 8 a.m. till if you're on call, well, all the way through the night. You didn't really have to do much at night. But you may easily be those sort of long days, even if you weren't working, you'd still be probably popping in and saying hello to me, because that's part of the sort of the common purpose and teamwork. And I think they managed, because the security, it got a bit easier. So at one point we were allowed into the town centre, so we did get 1 day off in the month. But I never felt tired. I never felt exhausted. Because we were genuinely helping each other. And this is a really silly thing, isn't it? But we got coffee whenever we liked. There was, the food was provided. And here's the thing. And then I come back to the NHS. I can remember this so well because it was August 2022, and I came back, and it was the first time I'd ever seen. I'd only been away a month, and it's the first time I came back, and there were double. I mean, sounds stupid now, but there were double figures of ambulances, waiting hours at the front door, and there were double figures of people waiting over 12 hours for a bed. Now, I know that's like normal now, but that wasn't normal then. That was an absolute shocker. And you can't even get a coffee. Like, you have to go to Costa. I mean, everyone else I work for, you get these things. It's part of, making you feel valued as part of a team. Anyway, really small things. It sound like really small things, but the difference was huge. And I'm not surprised that our well-being day to day in the NHS is so bad. I'm not saying that the organisation I was with has got it all right. I'm not saying that every organisation would do it as well as I experienced, or that everyone is having the same thing. They did have really good pastoral support. That was all there, but it was that genuinely looking after us and being part of one team that I just realised is so the opposite of what we have most of the time. So the lessons Rashad talks about wanting to advocate, coming back to UK and advocating, and it's a part of me is like, I want to advocate for change in the NHS, because there's no reason really why we couldn't pull together a bit better.
Absolutely. Thank you. That was really helpful. The other question is going back to getting involved, and obviously you've both sort of said just get involved, if that's what you want to do. The part of that, and part of the question that comes alongside it, is there anything that people should be doing in terms of training or volunteering or future career paths to enable them to go into this area of medicine, and to support them in that role?
If you allow me to start with the goals. So for every organization you will be applying for, it's always mandatory before sending you to a war zone to have a certain type of training. The training is across organization. You have a lot of similarities and, of course, some differences related to organization. So I would say first you should get engaged with some of organization who would have that training pathways. We called it competency pathways, which train you on a different profile before sending you to the field. There is a couple of online training. There is a couple of certificates, diplomas, masters in conflict medicine and in disaster medicine, which is allowing you to have the theoretical part of it. But my advice on this, or the way I have been engaged in this, is to volunteer with the organization, then get this particular organization training, getting deployed, seeing what other organizations doing, and involved in a different organization. That's at least the way I have been involved.
Yeah, I think that's right. I did the DMCC. I'm not sure what other options are out there. That was a good one when I did it. It's changed since I did it, but I think it's still really good. It's kind of, I did the DTM&H in terms of global health stuff as well, which is not sure, but the parallels for me are similar. You do something like a diploma and you'll learn lots of theory, not, to be honest, not much of which you're necessarily going to apply you're going to encounter situations that your diploma never covered, and you're going to learn stuff in your diploma that you're never going to see. But what I found the real benefit of both of those things, but for slightly different purposes, was the environment of being around other people who are interested in it and sharing stories and learning from others. It's not just the book work, but also it does open your eyes to the bigger picture. And that kind of is a really helpful grounding. But you could do at least the bigger picture stuff through really wide reading and being aware of what's going on in the world. But as Rashad said, what is critical is that you get that acute training sort of beforehand. So you might have done some groundwork years ago, but you're going to need that, and especially the security training before you go. So if it's not that organization, I said, we don't want little organizations that don't collaborate or don't. Not all organizations can provide everything. And that's fine, as long as that organization then says, right, we haven't got the capacity to do the security training or the trauma medicine training or whatever, but we have made sure that you've got that package from someone. So making sure you get that specific training is really crucial.
Thank you. We have 2 minutes left before the break. So I'm just going to put one more question to both of you, which I'm looking forward to your answers, actually. What's your most memorable, for both of you, or proudest single achievement in the magnificent work that you've done so far?
I'll just go quickly, because I think actually that may not have been just about the conflict stuff. So for me, if I'm going to take the last 2 sessions, I think the thing I was most pleased with was that course that we ran where Rwandans were teaching Brits and Aussies and Americans, because it was the first time I'd seen that in operation, that genuinely reverse, if you like, reverse roles as we have so often assumed roles should be. And it wasn't patronizing, and it was really good learning, and it was cheaper than an ATLS course, and it went on for 2 weeks. It was so much better. But yeah, that was the thing I was most proud of in that sort of low resource setting stuff that I've done for a while.
Thank you. Rashad, have you got anything?
For me, the thing that is I can recall now as an ops manager, to provide cold water for the Sudanese population movement on the temperature of 66 Celsius with no shelter available. That's the thing that I've always said that is my lifetime achievement.